Hi, today we're going to talk about shock. So, shock is the inability of cells to access oxygen and undergo normal aerobic metabolism. So, what that means is that all the cells in your body need oxygen so that they can break down glucose or sugar into ATP. So, there's four types of shock: hypovolemic, when you don't have enough volume; cardiogenic, when the heart isn't pumping; obstructive, which is when you don't have enough venous return to the heart; or um, there's actually something like blocking the flow of blood from the heart, so to the heart or from the heart. And then there's distributive shock, which is like maintaining enough blood pressure so that oxygen can actually flow, like like the red blood cells carrying oxygen can flow through the blood vessels. So the first type of shock we'll talk about is hypoperfusion. Or sorry, shock is just generally hypoperfusion, and there's three ways that can happen, and we talked about that. So reduced volume, loss of cardiac function, insufficient flow for oxygen delivery, and the body normally responds to not having enough oxygen in predictable ways. Your heart rate will go up, and that's because you're stressed. So you have stress hormones like epinephrine and norepinephrine. It's the fight or flight reaction, and your heart will start pumping really fast. Vasoconstriction. You're going to try and increase your blood pressure by constricting your blood vessels. So the hormones responsible for that are norepinephrine, vasopressin, and angiotensin. Diaphoresis, or sweating, that's from norepinephrine. Thirst, because when you're stressed, your cortisol level goes up. You'll have more sugar in your blood, and you'll be thirsty as a result of that. Reduced urine output, that's because vasoconstriction of the kidneys, so you're not going to be clearing out the blood as much, and that's from aldosterone, vasopressin, and cortisol. Hyperglycemia, too much sugar, we talked about that, and in general, you'll have inflammation. Okay, now the first type of shock, hypovolemic shock. This is when you have at least 30% of volume being lost. On physical exam, always check the neck veins. In this type of shock, they will not be distended. That's because you still have venous return and the heart is still pumping. You will not detect any heart murmurs, and the most common causes of hypovolemic shock are hemorrhaging, infection, trauma, pancreatitis, burns, vomiting, excessive sweating, and not drinking enough. So anytime that you're losing fluid or you're losing fluid out of the blood vessels, you're going to have a hypovolemic shock. In the case of pancreatitis, it's because you have all the fluids not being absorbed. They're being drawn into the bowel, and they're being excreted that way. So lab tests will show a metabolic acidosis. You'll do your ABGs, or arterial blood gases, and they will be abnormal. Blood urea will be high because it's not being excreted. Creatinine will be high, again, it's not being excreted, and sugar will be high. Treatment is either crystalloid fluids or colloid fluids. Colloid fluids are actually preferred because they won't mess up your electrolytes, and you can add dopamine if they're not responsive. Next type of shock is cardiogenic shock. This can be myocardial ischemia, it could be valvular disease, it could be an arrhythmia like bradycardia, VTAC, rapid supraventricular tachycardia, or it could be an end-stage cardiomyopathy. In this case, neck veins will be distended because the heart isn't pumping and there's backup. You will see on physical exam tachycardia, tachypnea, agitation, confusion, and if it's due to a valvular disease, you might hear a murmur. Investigations to order is a chest x-ray, and you'll likely see pulmonary edema. Cardiogenic shock can look similar to congestive heart failure. The difference is in cardiogenic shock, your blood pressure is really low, whereas in congestive heart failure, your blood pressure is usually normal. Metabolic acidosis, you'll see. Urea and creatinine will be high. You can order an echo, pulmonary artery catheterization, and cardiac catheterization. You treat the cardiogenic shock by cause. So, inotropic and vasodilation, intra-aortic balloon pump. In cardiogenic shock, you would only suspect this if there's known cardiac pathology. Otherwise, you would more likely go with hypovolemic shock. The treatment's a little different. In hypovolemic shock, we're treating it with fluids. and in cardiogenic shock, we are not treating it with fluids. And that's because it could overwhelm the heart. In obstructive shock, we have decreased venous return. So causes could be pericardial tamponade. That's when there's a little bit of fluid in the pericardium and it's increasing the pressure going back to the heart. So you've reduced venous return. This can happen acutely or subacutely. So acutely would be like chest trauma, and if it's acute, you may not have time to hear the accumulation of fluids, so they may have clear chest sounds and normal neck veins. Subacutely, that's when you know that something else is going on, and then this has come as a complication. Then you will be able to hear chest sounds. So it'll sound like there's fluid. So you'll have decreased tympany, and you may have reduced breath sounds. And then treatment would be pericardiocentesis, and that's when they puncture the pericardium with a needle and they take out all the fluid that's accumulated there. Another cause is tension pneumothorax. Tension pneumothorax can be spontaneous, which is when a little part of the lung, or a bleb, collapses, and that puts a lot of pressure on that side of the lung. It can also happen from trauma, and what you'll see on physical exam is decreased breath sounds, decreased tympany, tracheal deviation away from the area, because again, it's collapsing, so it's an area of high pressure, so it's going to push everything away from it, and distended neck veins. Treatment is to relieve the pressure that's there by placing a needle in the chest and then putting in a thoracostomy tube. You can also get it from increased abdominal pressure. So, like if you push down on your abdomen, what that's doing is decreasing the flow back to your heart. So, on physical exam, you'll see a distended abdomen, and treatment would be to increase the mean systolic pressure somehow, so whether that be vasoconstriction or not. Or you could also relieve it by opening up the abdomen. Either way, that it's a little bit of a tricky thing that should only be done by a trained physician. What can also happen in shock is something called systemic inflammatory response system, or SARS, SIRS. This is very severe inflammation. What happens is they either have a fever, a high fever, so over 38.5 degrees Celsius, or hypothermia in the more severe case. That's when you're not getting perfusion anywhere, so the temperature just drops everywhere. Heart rate is over 90, respiratory rate's over 30, and you have leukopenia, which is very severe. Normal response to inflammation is increased white blood cells, so this would be more severe. Presentation, vital signs similar to what we spoke about before. Mental status is impaired. You'll hear lung consolidation. There's likely an ileus. That's because when you have inflammation in the bowel, a lot of the exudates will accumulate, and they will almost accumulate as if it was a bowel obstruction. Oliguria, again, because the kidney's not being perfused, so all of those fluids are not being peed out. And then mottled cold skin, that's again because of generalized vasoconstriction, and increased capillary refill time because, again, you're not getting perfusion. On labs, you'll see a D-dimer is positive. That's because of all the inflammation. You have fibrin being formed and broken down. So that's where the D-dimer is from. You'll have increased INR and APTT because all the coagulation proteins are being used up. So the time it takes to coagulate again is much longer. Increased polymorphonucleosides, those are the first responders to inflammation, so those will be high. Increased hemoglobin, that's because of all the fluid which is in your blood is leaving and exuding into the extracellular space. So the hemoglobin, which is normally present in blood, will look a lot more concentrated, so it'll be higher. On a chest x-ray, this may look very similar to congestive heart failure. Again, the difference is in congestive heart failure, they are normotensive. In SIRS, they are hypotensive. You also order arterial oxygen and carbon dioxide. You'll find that the oxygen will be low and the carbon dioxide will be high. Calcium may be high, lactate will be high, urea will be high, sodium will be high, creatinine will be high, and glucose will be high. The treatment with SARS is to fix the cause. So whatever it is, whether it's cardiogenic shock, obstructive shock, hypovolemic shock, or distributive shock, you'll need to find out what's the reason. But the first goal is always to fix the low volume. And so you would immediately order 2 large bore IV lines, and you would use crystalloid fluids. So you just want to increase the amount of fluid, and you're going to need a lot. Usually it's a 3-to-1 ratio. Because they've lost 30% of their volume, you'll need to restore 3 times as much to get it to stay in the blood vessels rather than exuding out into the extracellular space. So to summarize, if you are in a situation where you see a patient who has low blood pressure, high heart rate, high breathing rate, cold to the touch or very warm to the touch, cool extremities, they may be agitated, they may have changed mental status, ask them how often they've peed, maybe they haven't done so very often. These people need critical care and crystalloid fluids. Thank you very much for listening.